Good afternoon. My name is Dr. Linda Ehrlich-Jones, and I'm here to welcome you to our webinar this afternoon on spinal cord injury, applying the principles of measurement to care. I would like to thank the Paralyzed Veterans of America Education Foundation for their support of this webinar by grant number 739. I'm pleased to announce our speaker, Dr. Matthew Sorensen. Dr. Sorensen is an associate professor in the School of Nursing at DePaul University. As part of his academic role, Dr. Sorensen teaches a course in program evaluation that is part of the Doctorate in Nursing Practice program. Dr. Sorensen is also a resource nurse working here at the Rehabilitation Institute of Chicago. So it is my pleasure, as I say, to welcome Dr. Sorensen.
Thank you. And thank you everyone for your interest and for attending this webinar today. So the initial idea behind this webinar is to really talk about how concepts of reliability and validity apply to clinical practice. And a lot of times people can sometimes be confused by these things. They think that these are concepts that are only relevant to the practice of research, but they really do inform a lot of the activities and the care that we provide in the clinical setting. So as a brief, we have our statement here showing that this is approved for continuing education through the Highlanders Association, and there will be a slide at the end that talks about how to go about completing that evaluation. They'll come as an email afterwards, and that completing the evaluation is required for you to receive credit. As an overview, this was in the announcement that went out. And really what we're focusing on is how measurement influences the care that we provide in the clinical setting. Particularly, we want to focus on concepts of reliability and validity in relationship to practice. And within the slides are some abstracts from some clinical publications that have occurred over the last several years to help reinforce what these concepts are, how they influence practice, and what interpretations can we draw from those abstracts from this research to be able to change patient care. So part of that is helping to identify what is reliability and validity in the first place. Why should we care? What really does it mean? And then discuss how that, again, applies to the care setting. So a lot of people seem to think that the idea of measurement, particularly from the research standpoint, is something very mysterious, something that involves certain courses, high-level discussion. Really, it's just a way of how do we find out information about something. In healthcare, we do this all the time. Almost all of our routine documentation is related to some kind of measurement. We listen to lung sounds, you listen to the heart. You're assessing a patient in terms of their level of anxiety. So we're doing assessments all the time. We're doing measurements. We're measuring some sort of parameter in terms of vital signs, depression, anxiety. So these are things that we're engaged in on a daily basis. And it's nothing really mysterious in that way. And what we then look at is, since these are things that we measure on a daily basis, how do we then approach ensuring that the things that we're measuring are reflective of what's actually going on with the patient? We have these physiologic measures. I know, blood pressure, pulse oximetry. But even with a lot of these physiologic measures, for example, with pulse oximetry, there are things that can throw off that assessment. Somebody who has nail polish on, somebody who's anemic, somebody who's experiencing hypoxia, are all going to influence the values. And with pulse ox, we want to pick up those changing oxygen saturation levels, so we can then determine when do we need to intervene. With all of these parameters, then there's a certain degree of trust that we have in their accuracy, in their consistency. And really, that's what we're talking about with reliability. We're talking about, are these measurements that we're doing consistent, and are they reliable? Can we trust what they say? Other examples from clinical practice, ASIA ratings are looking at that entire parameter of what is this person's function post-injury and deriving a rating from that. Some other measures that are becoming more and more common in a clinical setting, in rehabilitation in all settings, we have some sort of measurement of functional ability. The measures are used in some places, other places use the spinal cord independence measure. Some places use distance in terms of ability to ambulate using wheelchairs, walkers. There's a variety of timed ambulation tests that basically say how far can this person go in this length of time. And these are very valid measures. They're used commonly. Depression measures. We may not call it the Beck Depression Scale. We may not call it the Center for Epidemiologic Studies Depression Scale. But they're in our clinical documentation system, and we check off whether or not the person is meeting certain parameters. Do we see certain signs? Do we see certain symptoms? Fatigue is becoming something we're starting to chart on more and more clinically now as well. The Fatigue Severity Scale, which originally started with MS patients. The Brief Fatigue Scale in patients. We've come to understand that fatigue really affects quality of life. And we're trying to find different ways to measure this now in clinical practice. And for all of these tools, they've gone through a process of development. They've gone through a process where people have developed questionnaires, tools, measures. Some are completed by observation, but there's been a process of development where we start with a conceptual idea. What is fatigue? And how we're going to measure that. Then the tools people have pilot studies. They investigate which elements need to be included, which elements could be safely discarded, and we come up with a measure that then is tested. And we're trying to determine if that measure is reliable or valid, because we want to be able to trust those findings. We want to make sure that every time we give this measure, we're going to be able to see the exact same thing. And that's part of this idea behind measurement. Now, there's a couple of different ways that we look at measurement. There's this idea of direct measurement, the things that we can look at very easily. A temperature, someone's weight. If we're looking at the weight, we can pretty much trust that this is the actual weight. There may be some things that are off on the scale. We may need to make sure that the scale is calibrated, but by direct measurement, we're hopefully looking at that exact thing: weight, height, temperature, oxygen saturation, white blood cell counts, etc. For indirect measurement, where we're talking more about reliability and validity today, these are concepts that are usually much more abstract. Pain can be difficult to look at directly. I don't know what your interpretation of pain is. Everyone's going to manifest a response differently, so it's a little more difficult to assess. We can't just do one test and say, here's where that person's pain score is. We have different ways of trying to target that, to evaluate. How do I know if someone's coping well with a clinical issue or not? Are you able to perform self-care tasks? As mentioned, there's many different ways to assess that. So these are ideas that are often viewed in a more abstract way, but we're trying to assess pieces of them or certain parts of them to get a sense of where is this person at clinically, where does this person stand? And part of that is we need things that are going to be trustworthy. So if we look at this as a global whole, as an example of something being abstract, pain, we have a lot of ways we can look at pain. The standard way that most of us probably use is the Likert scale, where you can go, well, from 0 to 10, with 10 being the worst pain you've ever had in your life, where are you now? But there's also other places that use a line with kind of an anchor from 0 to sometimes 100 or even 10, and the person just draws across that line and indicates here's where my pain is at. That's the visual analog scale. There's also, I think most people are familiar in clinical practice with the long Baker Faces scale. So there's different rating scales besides the standard classic Likert scale that allow us to look at pain. And they're looking at pain from a little different way. The visual analog scale, where the patient draws a line and marks where they're at, is a little different than just giving us the set number that a Likert scale would. But all of these measures have to be trustworthy. We watch people. I'm sure most people have seen patients in clinical practice who are going, I'm not having any pain, but yet they're wincing, they're guarding themselves. You can tell they're having pain, but they're denying it. So through observation, we're seeing something else about pain versus what that, well, where's your pain at? 3, as the person is trying to clench their teeth to stop themselves from screaming. So what I'm seeing observation-wise is different than what you're giving me as a number. What if the person's unresponsive? Patients who are non-communicative because of the nature of the injury. Patients that are trach, who may not be able to communicate verbally effectively. Then what are we doing to evaluate pain in them? We have physiologic measures we can turn to. Am I seeing an increase in the blood pressure? Am I seeing an increase in pulse? Am I seeing some of those behaviors of somebody guarding? Do I have a measure there in terms of vital signs or something else that can give me something that says pain? So there's many different ways we can look at this kind of abstract concept. Now, if we replace pain with self-esteem, we would be at the same point. We can look at how someone's interacting with other people. Do they seem to be asserting themselves, or do they seem to be quiet and withdrawn? When they seem more confident and more self-assured, do I see a change in their vital signs? There's rating scales for self-esteem, and each of those scales has a different way to look at self-esteem. They have a different view of what is self-esteem, and that's one of the things that we see with a lot of the instruments that we're looking at today and in clinical practice. Conceptually, each one has a little bit different way that they see that particular concept. And that's why some people are starting to argue that we need to have more than one way of assessing. And so there are many different ways to measure the same concept. There's many different tools out there. As mentioned with pain, we've got the Vicar, we've got the one-finger facing scale, we've got visual analog scales. There's many ways to approach the measurement of that concept. And whether it's pain, self-esteem, ambulation, there's different ways to get at that point. And that's one of the things that we're starting to see more and more. This is an abstract from a study that was in 2008, where they looked at spasticity in patients with spinal cord injury. Now, when somebody says psychometric properties, they're talking about how does the tool score in terms of testing. Is it reliable? Is it valid? Is this an accurate measure for research or for practice? So that's what psychometric means, is what are the scores on these evaluation measures to make sure that this is an accurate way of assessing spasticity. What their conclusion was is exactly what we're talking about with pain. Spasticity is multidimensional, and that if we only use one or two different measures, we can't really necessarily capture the entire sense of what is spasticity. How do we evaluate that? That there's different scales that are measuring different pieces of that global concept of spasticity. And the interesting thing here is that one of the points they've made is that individual tools are not always well correlated with one another, which may say that this one tool is assessing something different than the other, that they're not actually measuring the exact same thing. And here they're arguing for a battery of tests to be used for spasticity. Now, that's really good for measuring that entire domain. I think a separate question then is clinically, do we have time to be giving lots of different measures in terms of patient assessment? You're working with multiple patients. Can you assess all of these pieces effectively within the time frame? So most hospitals or institutions have then chosen, this is our measure. This is how we look at this measure for pain. Here's how we look at this measure for spasticity. Here's our measure for anxiety. Here's our measure for depression. But as we look at those measures, that then comes into the question of how have we evaluated the trustworthiness and consistency of that tool. So when we're choosing a measurement, we have many different ways to measure something. We know it's only looking at part of the whole tool, but then what's the basis on which we decide from one tool to another? And as places are becoming very interdisciplinary, nurses, physical therapists, outpatient therapists are becoming very involved in conversations as to how we're going to evaluate this clinically. The entire movement of magnet hospitals, when nurses are being involved in these conversations, then we need to be able to participate in the discussion that says, how do I know this tool is valid? How do I know this tool is not? Is this tool reliable? And then what does it mean to say that something is reliable and what is trustworthy? What's accurate? So what's an accurate assessment? So using another measurement scale. This one looked at a depression scale. They did a study, and they did something called a test-retest. So they gave this test once, then they gave it again. So when you're doing that, you're trying to start to look at consistency. Is this accurate on multiple administrations and multiple delivery? Another way of doing that is there's another type of consistency where we're looking at how the items all kind of hang together on a tool, and that's called internal consistency. And we'll come back to that idea in a couple of minutes. But looking at this abstract, they've looked at how the items group together within the tool. They gave the tool twice to see how well it worked in each time. And they're basically saying, you know, we're finding some good relationship. The scores are consistent. That's the heart of reliability, is consistency. And the other element is then, is this tool really effective then at assessing depression? I may have something that's wonderfully consistent, but is it measuring what I think it should measure? A slightly different one, looking at shower commode assessment, talks again about we're seeing something that's multidimensional. So if we're seeing multidimensional elements, and we're trying to develop skills that are looking at different elements or different pieces of that content, how do I know that this is relevant? That's validity. Content validity basically means how do I know that this tool is looking at everything that needs to be looked at with a shower commode chair. Usually, how do we establish content validity? We go around and we talk to experts. So just from these brief examples, we can see that even with something like developing a shower commode, we need to know that these tools are going to be effective in terms of evaluating their usefulness within the clinical setting. So looking at these abstracts, what we're seeing is the authors evaluate the consistency of their scale, and then they also evaluate whether the scale is actually measuring the construct or concept it's supposed to be measuring. So in other words, they looked at the reliability. So as we start to look at different tools, tools related to bladder function, tools related to bowel patterns, ambulation, preparation for community practice, we want things that are going to be reliable and better. So how do we make those judgments? The accuracy of the measurement becomes the big thing. If we're looking at the ideas of any of the other tools or measures we've used, we have to make sure that it's going to be consistent. And we want to make sure that it's going to be reliable. And as we've mentioned, this is the main point of what we're talking about. Part of what this is we're looking at is the idea of measurement error. So there's an idea out here that we can evaluate someone's temperature, but we have many different ways to do it. Spinal cord practice, a lot of times we do axillary temperatures, but those are not the core temperature. They're different. So they vary. So methods of measurement will vary based on how we collect that measurement, how we collect that data. So an axillary temp is generally going to be a little bit lower than an oral, but an oral is going to be lower than a rectal. And tympanic is really often influenced by the environment around the person. Somebody comes in from the outside, you put a tympanic thermometer in their ear, it's going to read lower if it's cold outside. So all of these measures have some degree of variance, some degree of error. They're trying to get at this idea of temperature, but first off we have to say, what is the temperature? Is it the core temperature? Is it a proxy that says, here's the relationship then with rectal, which is what we're doing with oral temperature, what we're doing with axillary temperature. We're trying to get a good sense of how well these match up. And that's part of, again, our concepts of reliability, but looking at how accurate our measurements are and how trustworthy they are. We need consistency. We need accuracy. We see this all the time in clinical practice. The glucose monitors are an example of trying to control for error. So when we talk about measurement error, we can talk about two things. Systematic, which means our calibrations are off. We're not calibrating our glucose monitors properly. The solution is old. It's out of date. The test strips are expired. So a systematic error is just saying we're making the same mistake all the time. And what we're trying to do on night shift, day shift, whoever calibrates the glucose monitor, is we're trying to control for that error. So we test them every day, and we look to see, are they consistent across time? And that's a way of trying to control for systematic error. Random error just means it's not something that may be related to the device. Someone's hearing may be more sensitive than somebody else's. Your stethoscope may be a little different than somebody else's. Can we all hear the exact same value when we're listening to a blood pressure? There will be slight differences. This is that idea of random error. So by using measures that have shown to be reliable, we're trying to control for some of this error. We know it exists, but through the use of a tool that's been tested, that's consistent, that we believe to be valid, we're trying to control the degree of error that exists. Part of this is also then related to a research concept that talks about different levels of measurement. So when we're looking at concepts in a clinical setting, we have to look at how we look at it. Nominal measurement is just basically yes-no things, dichotomies, things that break up into 2 or sometimes even 3 categories. It's just, there's no scoring between them. So we could have yes, no, in terms of you having pain or not, but that doesn't tell me are you having more or less pain than you had earlier. So we can have ordinal measurement where somebody has low pain, moderate pain, they have severe pain. It's not a 0 to 10. I mean, if you're telling me you have a 5 on pain, and then later you tell me you have a 10, is 10 twice as much as 5? Or is that just really a sense we're trying to have to see if things have changed or if things have gotten worse? So we have other types of measurement like interval, where we have changes in temperature, 5, 10, 15, 20, but 20 degrees Celsius is not exactly double 10 degrees Celsius. So there are meaningful degrees of distance between these measurements, but then the final level is really the most accurate, which is the ratio. So if you're looking at somebody who weighs 10 kilograms, that is double 5 kilograms. So there's an actual same difference across that time, or that measurement. And these are things that a lot of the tools that we're seeing in clinical practice are trying and capture. They're trying to look at, can I get a sense of, on this measure, if you actually are going to have a value that actually is twice what you had previously, or is it just, again, an estimate, a proxy? So reliability is that concept of consistency. We have a couple of different ways that we can approach it. We can have stability, equivalence, or homogeneity reliability. And these are all reliability is looking at, is we can look at consistency of measurement. It doesn't tell me that this tool is actually measuring what I think it measures. It just tells me this tool tests consistently over time. That's why we need to have validity. We need to know that it's actually measuring what we think it measures. So stability. Am I going to get roughly the same scores now and the same scores later? Blood pressure. If I check it using this cuff one time, am I going to see an accurate values if I check it again a second time? So I should see consistency of measurement. I should see accuracy across time. It should be measuring the same concept every time I give it. They usually will compare this in research by correlations. And they'll just basically look and say, how are the scores correlating with one another? And is that correlation a strong one? Which basically says the scores the first time match up with the scores of the second time. For equivalence reliability, there's a couple of ways to do that. And the second one is the most common. The first one would be is you have, say, 20 different items. You want to go with a 10-item scale. You're going to compare the 20 different items together. So you have 2 versions. Maybe you've mixed up the order of the items, and you're seeing if that changes anything, you're looking at your results across two different forms of the same thing. What's more common nowadays, particularly in clinical applications, is having two people measure the same thing. So an example of inter-rater reliability then is if I have three nurses measure blood pressure, if I have them measure a pulse, will I get the exact same value each time? For a pulse, I would hope so. But for the blood pressure, there may be some changes because of how we hear. One person may have a little bit more sensitive hearing. So if everyone's using the same stethoscope, everyone's using the same blood pressure device, will I get exact measurements each and every time? No, but they should be within an area of strong correlation with one another. So we'll look at the correlation, we'll look at how these values compare together, and then we can say, can I trust this measurement? You almost never, you never see a correlation of one which is a perfect correlation. There are going to be changes, particularly in terms of something like blood pressure. But the scores should be fairly consistent. And that's what they're looking at with inter-rater reliability. So if one person gives you a measurement tool, somebody else does it later, I should see responses that are fairly comparable with one another. I should see consistency. Homogeneity reliability is, if you look through the nursing research and a lot of physical therapy research and others, you're going to see a lot of people talk about Cronbach's alpha. It's really common. It's almost like do rigor. If you're going to do a study of some kind, you have to have Cronbach's alpha. What a Cronbach's alpha is, it's basically a coefficient. It's like a correlation. And what it's trying to say is it's trying to say, do all the items on this measure, so if I'm looking at, say, a measure of stress, are all of these things looking at stress, or are some of these items reflective of anxiety, or are they reflective of depression? So Cronbach's alpha is trying to say, are all the items on this tool looking at the same thing? It should be higher than 7, which would be considered a good correlation. The one thing that you're seeing a lot of times in the literature is they would like to have the upper limit of that around 9.9, 0.95. Because if it's much higher, that means all the items are assessing that exact same thing. So in which case, why do I have to have 10 questions? Why can't I just go with 5? So if everything is too high, particularly if something has subscales, if you've got a 20-item tool that's then broken out into 4 subscales of 5 items apiece, but I've got a very high alpha, then what that's telling me is it's saying that these subscales are really probably not that much different than one another. But it's all looking at the exact same thing. And that's why when somebody's doing a study, they should be looking at subscales and the entire measure as well. And that's the one thing with Cronbach's alpha is you want it high, but if it's too high, it means this tool probably has questions that it does not need. So that's reliability. We need consistency. We need kind of reproducible results with reliability. Validity, however, is starting to look at, is this really looking at what I think it looks at? So is this reflective of what we think? Now, a couple of places will talk about something called face validity, which means it looks good. But I don't know that it really is good. It just looks good. It's kind of like the TV commercial, tastes great, less filling. Okay? Well, it may be, but I don't know. And that's the thing with face validity is you'll see places report it, they'll discuss it, but that's all it is. It's just looking, it looks good on the face of it. But we have to go a little bit further because if we're going to use this to make decisions regarding care, we need to definitely be able to trust it. So there's 3 classic forms of validity. Construct, which basically is asking, does it measure what I think it measures? Predictive, does it relate statistically, or can it predict something? And then content validity, which basically means, does it hit everything about this concept that it should? So let's use, say, stress as an example. So if I'm looking at construct validity, it should be measuring stress, or whatever my interpretation of stress is. Predictively, it should be able to predict a degree of stress on the part of a patient, or an outcome. So if somebody scores this high on, say, a stress measure, then I should be able to anticipate, is this person going to be able to handle this condition well? Is this person going to have problems with coping? It should be able to tie to some outcome that says, I need to do something now, or I need to engage in some interventions to protect something from developing in the future. The fatigue measures, where we're trying to look at, will this person be able to handle therapy or other activities? So we're looking at fatigue, but then we're trying to say, does it predict their ability to function? Whereas content would basically be asking, does it look at everything that stress supposedly is, or is it leaving something out? And there's different approaches to all of these. The next two slides, I am going to focus on construct and content. I don't have a slide on predictive validity, because more and more that's becoming statistical. People are using a lot of statistical tests now to try and predict that. An example of that would be NCLEX. If you've taken NCLEX, what predicts your ability to pass NCLEX? In a lot of places, GPA, which is why there's this kind of almost obsessive focus in nursing schools on a particular GPA, because it predicts your ability to pass NCLEX. That would be an example of a predictive validity. The other would be is for most of us who have gone through nursing programs within the last few years, they've had things like HESI, Kaplan, ATI. They have these testing services that are trying to predict your ability to pass that content, that NCLEX content, while you're still in the program, to determine, do we need to do something about this now? Do we need to intervene? Do we need to do some remediation? Do we need to do some review? That's what predictability is trying to look at, is can we take the information from this and predict an outcome? And more that's becoming statistical now. So construct. If I'm looking at a stress measure, how do I know this is stress? Or how do I know this is depression and not stress? There's actually a well-known stress tool out there in the literature that a lot of people argue doesn't measure stress. It measures depression and anxiety. And you see people argue this back and forth in letters to the editor and in articles. And that's the important thing, is how do I know that I'm really looking at stress? So there's a lot of convergent tools. If I'm going to look at stress, or just to stick with what the slide's showing, depression, how do I know that my tool is really looking at depression? Well, I can find other tools that look at depression, and I can examine how this scores. Does it score consistently? Does it correlate well with the other tools? In other words, if other people are measuring depression, is my tool doing the same thing? Discriminant, though, says, well, okay, am I looking at depression or am I looking at stress? So I get a bunch of stress tools, and I give them two. And then we're looking at, I should see differences then, because now I'm looking to distinguish or discriminate between two different concepts. And that's the idea of what constructive validity is, trying to look at comparing it with other existent measures, seeing how well it matches up with them, and then how well it also differs from them. So I find tools that look at a different concept. I shouldn't be getting really tight relationships between depression and anxiety. There is a relationship between the two, but my tool should still be able to tell the difference and say that it's looking at this and not this. That's what discriminants are trying to do. Now, in terms of content validity, how do I know that my measure is looking at fatigue, or has it left something out? Have I looked at all the symptoms? Have I included everything? Am I looking at the fatigue that you may say with patients with MS, where it's this crushing fatigue in the afternoon or the early evening? Or is this the fatigue that you see sometimes with chronic fatigue syndrome, where it's post-exertional? So what kind of fatigue am I looking at here? And have I left out something? Have I included things? How do we know that we have content validity? Going back to one of the abstracts that we talked about a few minutes ago, we asked people. We asked people who know the field. We asked experts on fatigue. And we asked them, is this reflective? Does this include everything that it needs to include, or do I need to rework this and consider add in some additional elements? Or have I put things in here that really aren't relevant to fatigue and I need to change it? That's usually how content validity gets established. We go around and we ask people who know the topic their opinion. So clinically then, tying all this back into the idea of clinical practice, every tool we use is based on a conceptual idea about that concept. So if I'm looking at a fatigue measure, it's presuming certain things about fatigue. The fatigue in multiple sclerosis patients is different than the fatigue in people with chronic fatigue. So if I'm looking at, is one fatigue scale going to then measure fatigue in everybody? But we know that the fatigue manifests differently. It's a different symptomologic presentation. It has a different naturalistic history in these patients. That's why we still see certain tools that are looking at certain concepts, because it manifests differently in different populations. Or if you have fatigue related to anemia, I'm going to also see a different presentation of fatigue. And each tool is going to be based on that conceptual idea. How do they see fatigue? And that has to do usually with a specific population. While information from those measures is going to guide treatment, if you're scoring really highline fatigue all the time, maybe we need to think about what kind of resting activity patterns are being done here. Do we need to adjust what's going on in terms of that patient? Now, these are things that we've done clinically for years. You see your patients looking short of breath. You see your patients looking tired. You decide, hey, let's give them some break here. What's happening now is we're trying to quantify that, because then we can go to insurance agencies or funders or looking at reimbursement. It gives them a score that says this person is having this problem, and then that information can be shared. If I say clinically, I'm seeing this happen in this patient, they're tired, they're exhausted after therapy, I don't really have a score that I can share with somebody at another facility. I can share that as verbal report, but more and more people are looking for a score. And that's what these tools are trying to provide. They're trying to provide a score that can then be used across settings to give somebody an idea of what is this problem. A lot of the functional measures are used to decide patient acuity, and that determines staffing. In most clinical settings, I'm sure people have participated in your patient acuity report for the shift. And that then determines as to how many people should be scheduled for the next day, how many people are needed to take care of this group of patients. And we're using measurement to decide that. And so I have to know is, if I'm looking at a measure of patient acuity, is it accurate? Is it valid? Was something left out that needs to be included? Did we forget to include the bed patients? Clinically, then, we have to have a sense of how this is going to influence the decisions we're making in terms of staffing, in terms of even sometimes the physical structure and design of a unit. Do we need to look at how we rearrange some of the patterns? Do we need to adjust the report? Also, outcomes. More and more, a lot of the documentation we're doing is being looked at in an aggregate way. To say, has the patient met these outcomes? Have they met these goals? Have they demonstrated progress? Can this person stay in the hospital for another 2 or 3 days, or do they need to be discharged? A lot of people are looking for a score. They're looking for a number. And then, but what is that number reflective of? So if we're using a measurement tool that decides whether or not somebody's ready for discharge, or ready to go home, or has the family completed the necessary teaching, we need to make sure those tools are reliable and valid. If they're not reliable and valid, then we need to look at how can we help participate in establishing that reliability and validity so that these things are trustworthy for use in a clinical setting. Clinical issues, we're seeing scoring measures now. We're seeing measures for pain. There's scoring measures being used in the clinical practice setting for neuropathy. There's depression, anxiety measures. We evaluate substance abuse or the potential for substance abuse on the part of patients all the time. Skin integrity with the Braden Index and other scoring systems that say, is this person at risk or not? Mobility and ambulation, clinical function, the new sepsis measures, looking at whether or not we're predicting predicting that this patient's going to develop sepsis. These are measures we need to make sure that they're valid. We need to make sure they're trustworthy. Clinical decisions are being made in terms of care on patients on the basis of how they're being measured. And we need to make sure that people are being measured accurately, that the tools are doing what they're designed to do. One of the things that kind of comes back to this is we're all familiar with Hohenstein. And for years, Hohenstein was kind of a chalice. It was like your patient has a DVT, well, do they have Hohenstein? But now we know Hohenstein isn't very sensitive. Oh, there's a lot of reasons you can have pain in the back of the calf. And it doesn't necessarily mean you have a DVT. So there was this measure we trusted that people used for a very long time, but we now know it really doesn't have the tight relationship to what we thought it had. And that's one thing to consider with all of the measurements we're starting to see. Is this trustworthy? Is this something that's going to be able to allow us to continue to make clinical decisions, or do we need to be involved in a larger conversation regarding this tool? There's a famous depression measure that you don't see used as much in clinical practice now because people argued it was culturally bound, that it was only good for people of a certain background, of a certain ethnicity, because it didn't recognize how depression would change across cultures. And you don't see that tool used as often now, and that's why, because it didn't turn out to be valid for other cultures. And that becomes a concern moving forward. So just as a final example, looking at pain and quality of life, this study was basically looking at patients with some intractable polyneuropathy. And they did lead implantation to try and look at treatment and determine whether or not treatment was successful. So they scored pain intensity, but they scored it using an 11-point numeric rating scale. And then they had patients' global impression of change. So we're seeing even now a clinical study where they're using a measure of pain that's different than what most people would use normally clinically. And what was their global impression of change scale? How was it validated? How do we know it was reliable? So even in studies happening now, we have to ask the question, is this being compared with what people have done before? Is it consistent as a measure, and is it a valid measure? And these things determine clinical practice. This was a study where they basically argued that this was an effective technique on the basis of what they did. Well, we need that data to determine whether or not we trust your measurement of that pain change. And they're arguing that the predictive value was looked at, and ultimately the conclusion, which I deleted from here because I was trying to fit everything on one slide, was that this was an effective technique. But that leads again to that question of we need to know how reliability and validity was established, particularly in something that's going to influence patient care. So I thank you all for your time, for your attention, and I believe we're opening it up for questions now.
Thank you, Dr. Sorensen. We do have a few minutes left that we can answer some questions. I can ask a quick question. So, Dr. Sorensen, what are probably the most common measurements that you see in the spinal cord injury patients that you take care of? What are the things that you're usually measuring?
Pain. Pain is a major measurement. Efficacy in the treatment of that pain, because sometimes that pain is difficult to treat. And as with the final example of this, you're seeing that there are researchers using a different pain scale than would normally be seen in practice, which raises that ultimate question. We do have a question as to what's meant again by measurement error. Measurement error is just saying how accurate can I know my means of evaluation is. So blood pressure. Is there a problem with my evaluating blood pressure because the cuff is wrong? Am I using the wrong cuff size? We know that if you use a cuff that's too big for somebody, you're going to get an artificially low value. On the other hand, if you use a cuff that's too small for somebody, we know we're going to get an artificially high value. So we know that. That would be systematic error. It's a means of measuring things, but it's because we're doing something to measure it that's wrong. Whereas with random error, it's just something that's occurring. Am I assessing measurement, but am I having some problems with hearing today? Or is it just, do I have a cold and my hearing, and I'm not hearing well because I'm stuffy and congested? That would be that idea of random error. So measurement error is saying there's two sources. how I'm doing it, what I'm using to do it in terms of like the blood pressure cuff or the procedure. But then there's also, as we could say, operator error. So there will be some changes from based on who's doing it. How do we reduce this error? Well, how we reduce this error is we try to make sure the things that we're doing are reliable and valid. We're trying to make sure that our measurements are consistent. Integrated reliability. If it's me and I'm having a hard time doing blood pressure that day, if one of the other nurses does it, are they going to get similar values? Do I see consistency across different people assessing it? Or if I know there's going to be a problem with this blood pressure cuff and we show this clinically, every unit probably has blood pressure cuffs that we use electronically. It's very common now. It saves us time. It makes it easier to move from patient to patient and assess it electronically. Almost all of the electronic measures, though, are thrown off by patients who have AFib. And we know that. So are we still doing electronic blood pressure measurements on patients with AFib? If we're doing that, that's going to be a systematic error. Because we know there's an issue, we need to fix that. So it's being aware of what are the errors, what can cause that errors. Knowing that there's going to be a problem with this measurement, then we need to look at the things that we can do to try and fix that. So in terms of assessments related in acute care, for an acute spinal cord patient, some of the measurement tools I'm seeing are evaluating the patient's risk for sepsis, evaluating the patient's risk for skin breakdown, looking at measures of trying to predict how well someone's going to cope with injury, which is a very abstract concept. But I'm seeing more measures in a clinical setting that are trying to do that, predict what's going to be the psychological outcome for this person. So these are measures and instruments I'm seeing used in acute care, trying to monitor for the risk of physical issues or the complications of immobility. And then looking at what are some of those other ramifications post-acute care. We try to prevent the skin breakdown, we try and enhance mobility, we try to prevent atelectasis, and there's a lot of little measurement tools that have been created to try and help us avoid that. But the one I've seen that's been added on most recently is the one looking at the ability to predict sepsis. And then the question is this going to be something that we know what the reliability of this tool is? Is this something that we can trust? Does it have predictive ability to predict sepsis?
So I'd like to thank you all for joining us today for the webinar. We will be having an additional webinar in May, so please keep posted for further announcements. You will be receiving an evaluation shortly by email. If you are a nurse seeking continuing education, please fill out the evaluation. It is mandatory in order to get that credit. We would, though, like to get the evaluation from everyone who has participated today. Thank you so much, and have a good afternoon.